Okay, so today I wanted to tell you about a really cool story about a patient that came to see me that was suffering from runner's knee, and through one running gait analysis, we resolved her knee pain. Let me tell you all about it. So, usually when runners come and see me, they're coming for a specific reason. Either they want to be safe and they want to get a running gait analysis because they want to be safer when they run, or they want to resolve an injury or pain. Or lastly, sometimes they come because they want to be faster. They want to be more efficient when they run. They want to be able to run with better ease. Now, with this patient in particular, they came to see me because they were having pain only when they ran, but they were having pain in their knee. Specifically, they were having what they thought was a history of runner's knee. And so when they came and saw me and we did a running gait analysis, she explained that it was only when she was running that she got pain. It would be after maybe a mile, 2 miles, maybe 3 or 4 miles, but that usually during a run, it would come up. So I kept that in mind and I talked to her about her shoe wear. I talked to her about all the different ways that she ran, some of her mileage, some of the things she tried in the past, like traditional PT. And we decided that a running gait analysis would be a good idea and that would be indicated. But also, I already had in my mind some of the key things I wanted to look out for. So let me tell you all about this patient. Let me tell you about some of the things we found on our running gait analysis and some of the clinical treatment approaches that we did. And then I'll explain some of the clinical reasoning behind why I did them and the background of how we implemented these things. Now, just so you know, this information is also on Solutions Education blog, so you're welcome to find it there. Some people are more of a visual learner, others are more of an auditory learner. Whatever is best for you, we do have the information over there if this information gets a little too verbal or a little too wordy. I'll give you the background and then we'll talk about some of the treatment and the approaches. So background for this patient, when we did a running gait analysis, we found a couple things. So we found that she had some gait deviation. Specifically, she did a heel strike at initial contact. Now that heel strike at initial contact, certainly there's different degrees. She had a pretty excessive heel strike. Now I can give you the amount or the number or the degrees, but a lot of people calculate these a little bit different. So what I'll say is she had a prominent heel strike, she had some excessive dorsiflexion, and she also had some overstriding. Now, for any of you that don't know, overstriding is when you put your foot in front of your hip while it's landing at initial contact. Now, you might think to yourself, does anyone put their foot behind their hip during initial contact? And the answer is no. You'd fall over most likely when you're running. However, overstriding is characterized by putting your foot significantly in front of your hip while you're running. Think of the classic person running that's really stretching their foot really far in front of them to grab the treadmill and to put their foot down when they're running. That is overstriding. The patient also had a couple other things that were present. She had limited terminal hip extension, meaning that she wasn't really finishing her strides behind her that well. She also had a lot of vertical displacement, meaning she was going up and down while she ran quite a lot. Her cadence was 165, and also I took a measure of her shoe wear as well, and we found that she had high heel drop shoes, high cushion shoes, and high arch support shoes. Additionally, she was running at a treadmill speed of 8 miles per hour, and I could hear her really pounding on the treadmill when she ran. Now, in addition to a running gait analysis, I also did a couple objective measures as well. So I found a couple key factors here, and that was gluteus max strength and a manual muscle test. So our classic 5 out of 5, 4 out of 5, 3 out of 5, that whole scale. So I found that she was at a 4 out of 5 bilaterally, gluteus medius 5- bilaterally, quadriceps 5-, but I'm going to tell you one of the most important parts, and that is plantar flexion was a 4+ out of 5 bilaterally, and gluteus maximus was a 4 out of 5 bilaterally. So remember those two parts. Also, hip flexion was normal, range of motion, however, hip extension was 10 degrees on the left and on the right 15 degrees, so a bit limited. And then single leg squats, she was able to do 10 with good form, bilaterally, no pain. She had some tenderness over the patella, and she had a positive Ober and a patellar tracking lateral on both sides. So we found some positive things, and you might be kind of thinking to yourself, okay, I can see why she might be having some patellofemoral pain syndrome. You might also be thinking to yourself, well, what other measures would I do? There's a ton of different measurements you could take. There's a ton of other findings on a running gait analysis you might be looking for or might include in this criteria. I'm just telling you some of the examples of the things I found. And I'm also telling you some of the most common things that we find, and that's why I picked this runner or this patient, is because these are very, very common things that we find. So in review, some of the biggest things to think about here would be that this patient is doing a heel strike. They have excessive dorsiflexion at initial contact. They're overstriding. They're having limited terminal hip extension. Also, she has a fairly lowish, although it's normal, fairly lowish cadence 165. She's also in some pretty high heel drop shoes, high cushion shoes. Those things are going to be important. Gluteus max is going to be 4 out of 5 bilaterally. Also, plantar flexion or gastrocnemius soleus is going to be 4+ out of 5. So let's take those and then think about a treatment plan for this patient. So a couple things when it comes to treatment plans. We want to kind of think about our approach into 3 different categories. And I like to think of it as what running form cues I'd give the patient, also what corrective exercises or therapeutic exercises I'd give the patient, and then any changes to their footwear. Now, there's a lot of different things that you can do, and there's a lot of different categories you can get into. However, I'll keep it within those because those are going to be most important to this patient. So one of the things I'd say is let's think about the category of running cues first. So what do we want to do with this patient's running cues? Well, a couple things in particular. First, we want to get away from some of that heel strike, overstriding, and impact through their body while they're running. So if we're thinking about this patient, they're landing with the heel strike, they're landing at overstriding. What can we do to get away from those high ground reaction forces? In other words, what can we do to prevent the impact going through their body while they run? Well, a couple things that we can do, but let's first dissect why we want to do this. If you think about it, putting your foot in front of your body while you run or landing on your heel with your toes really far up, all of that causes you to stop your momentum going forward while you're running. And if you're stopping your momentum going forward while you're running, you're essentially putting braking forces or causing your body to stop, basically stopping the forward progression of gait while you're moving. And as you do that, you are then causing your body to take that shock and absorb all that impact from the ground. We call these ground reaction forces. So they have high ground reaction forces, and as you think about it, those high ground reaction forces are going to go through the lower extremities, through the foot, through the ankle, up through the knee, up through the hips, up through the back. So for someone with runner's knee that's having some patellofemoral pain or increased pressure in the patellofemoral joint, we want to decrease that. So what are some of the running cues we can give this patient? Let's have them run more midfoot. Now, I don't expect this patient to run midfoot. I might give her a cue to run midfoot, but I actually just want her to land on her heels more soft. So I might just tell her that. Run on your heels more softly. Or I might tell her, run like you're pretending to run on eggshells. So essentially, we're getting some of that excessive dorsiflexion heel strike off. The other thing we want to tell this patient is to lean slightly forward while they run. Let's get the body and the trunk more forward. One of the cues I'll use is act like you're falling forward while you run. And that can help the patient to get the pressure off the feet, to get the body over their toes a little bit more, but also to make it harder for them to overstride, harder for them to heel strike due to flexibility and range of motion, and also get the momentum to push behind them. So to cue up that posterior chain and really get that behind their body movement or activation more while they're running. Which leads me to my next point of corrective exercises. So what corrective exercises could we give this patient? There's a couple. And we could give them so many different corrective exercises. I'm just going to talk about 2. I would give them some strength in their gluteus maximus and their plantar flexion muscles. So in that case, what would I give them? I'd give them single leg heel raises. So I'd have them do single leg heel raises to fatigue. Make sure it's good form, good arch support. They're making sure that they're going to be able to go through the big toe and really push up. So they're putting the pressure right. Now, in this case, we want to make sure we're activating those plantar flexion muscles, the gastrocnemius, the soleus. So you could give them single leg heel raises both with the knee bent and knee straight. And this is going to help to get them to be able to land more midfoot or less off their heel. And it's going to allow them to have that better form and make sure that they're not going to get another injury in their calf musculature or their posterior chain, their lower extremity while they're running. The other thing I do is give them single leg bridges. And that would be something that can get engagement of their gluteus maximus muscles, again, improving that hip extension and making sure that they're finishing their strides while they run. So we're getting them to get that whole posterior chain more engaged, stronger, so they can finish their strides behind them. The hope would be they're finishing their strides behind them, and they're then able to do less overstriding and open up that stride behind them. And I know I told you only 2, but I'm going to add a third one in here, and that'd be a rectus femoris stretch, maybe an iliopsoas stretch as well. And so if I gave them maybe 1 set of 30 for the heel raises, or 2 sets of 30 for the heel raises, and then maybe 2 sets of 15 for the single leg bridges, I might give them 2 sets of 30 seconds for the stretch and a static stretch. You can make it a dynamic stretch if you maybe feel like that might be better, but some type of stretch for the hip flexors would be indicated. And then lastly, we'd get into the shoes. And the different shoes this patient would want to run in. We did a blog article, we did a podcast, we did a YouTube video on high cushion shoes and how they actually cause more impact through the lower extremities while you run. And if you haven't checked that out, please do. There's a lot of great information in there. The bottom line is high cushion shoes put more impact through our bodies while we run because they increase the ground reaction forces. Mostly, and the bottom line is really that people run harder in cushiony shoes because they kind of feel invincible. They feel like they can run harder and faster and pound on the ground more in these high cushion shoes. And so those high cushion shoes are actually causing more impact through the lower extremities, more impact through the patellofemoral joint in this case. So we'd want to get her out of the high cushion shoes. Give her more of a moderate cushion shoe. And I'd also give her something that had moderate cushion, moderate arch support, and I'd get rid of that heel drop. So I'd make it a moderate to moderate low heel drop as well, because with the excessive heel drop, we're actually going to be promoting a heel strike more and early heel striking when they're landing on the ground. So in summary, I'd want to get this patient off of her heels. I'd want to get her more not only midfoot striking, but also leaning slightly forward while she runs, giving her the cue to run soft or run light on her heels or run more midfoot. I'd also give her the cue to lean more forward, so act like you're falling forward while you run. We'd want to engage her posterior chain, gluteus maximus, plantar flexion muscles, maybe do a stretch for her hip flexors as well to get them to have increased mobility. And then lastly, we want to get her out of the high cushion shoes, make sure that she could actually get into some moderate cushion shoes, moderate stability shoes, and moderate to moderate low heel drop shoes. Now, the wonderful thing about this patient was after 2 weeks, she emailed me and she said, "I can't believe it, but my knee pain went away." She had had this knee pain for years and thought it would never go away when she'd run, and she was so happy about it. And I was so happy for her, not only as a runner that had dealt with issues of my own in the past, but also as a PT that I could provide her the options and the solutions to her issues, that she actually got better and that she was able to go do the things she loved, like run. And as PTs, we have such great clinical knowledge, we have such great clinical reasoning, we have such a great background in musculoskeletal disorders and running that we can apply our PT knowledge to our running gait analysis and create a great comprehensive plan for our patients that will truly get them better and kind of integrate not only our running gait analyses into PT treatment, but also vice versa as well. For this person and this patient, it was great to see. If you do have any questions about this, let us know, contact us, share a story of your own that you've had with a patient in a running gait analysis that's either done really well or maybe was a difficult case, and we'd love to hear from you. Until we talk again and see you again, take care, and if you do have any other thoughts about content or things you want to hear, let us know. Until then, stay well.